All right, we are going to continue. We have another wonderful speaker before we take our next lunch break. Without further ado, I'll introduce Dr. Doug Powell, who is a legend um, when it comes to being a speaker and a wonderful instructor and clinician. And Dr. Powell, it looks like you're sharing your slides. And I just want to confirm, will you handle your own polls, or would you like the ACP staff and Steve to do that?
To do the polls.
Ah,
Uh, yeah, so I'm not totally sure on how to do it, but uh, yeah, why don't you folks do it?
okay, sounds good. Thank you. So without further ado, I will turn it over to Dr. Powell.
Okay, well, welcome everybody. I appreciate getting the opportunity to talk with you, and I'll be talking to you a lot in the next couple of days. We're going to cover liver disease. I tried to focus on a lot of the types of things that I think will get asked, and so with no further ado, let's jump right into a question. A 44-year-old woman presents with a 4-week history of anorexia, nausea, and abdominal pain. She stopped drinking alcohol 2 weeks ago because she felt too sick to drink. Past medical history, long history of alcohol abuse, 24 years, depression, hypothyroidism. She's taking only levothyroxine and fluoxetine. Her temperature is
Hi, good afternoon. Dr.
38.2.
McGinty is not here today, so Dr. Felder.
Her pulse is 120. Blood pressure is 90/60. Eyes scleroticteric. Skin is jaundiced, phytoangioma present, enlarged liver that's tender, trace edema, and she's only oriented times two, but does not have any asterixis. Her AST is 100, ALT is 35, alk phos is 200, bilirubin 40, almost 41, direct bili 19, albumin 2.6, INR is 2.4, platelets 90, hematocrit 38, white count 11.2, MCV 104. What is the most likely diagnosis? Autoimmune hepatitis, primary biliary cholangitis, drug-induced liver injury, Budd-Chiari syndrome, alcoholic hepatitis, or acute cholecystitis. So most of you are picking the correct answer, which is alcoholic hepatitis. Um, And this patient has a bunch of things. One of the things I think we all jump to is the remarkable elevation of AST compared to ALT, that alcohol tends to depress ALT a bit and you'll leak AST. So you'll see this 2.5, 3, 4 to 1 pattern. The other real pearl there is that the AST never really goes all that high, and really rarely above 200 and almost never above 300. So seeing people with life-threatening alcoholic hepatitis with ASTs of 90 or 100 is not uncommon. So a ratio of over 2 to 1 suggests alcoholic liver disease, and the ratio is almost always less than 1 with viral hepatitis until cirrhosis occurs, at which time the ratio rises to 1 or slightly greater to 1. So that's the other thing you can know about these AST to ALT ratios. The most important is the alcoholic hepatitis being more than 2 to 1, but the viral hepatitis tends to be under 1. So what might improve survival for this very sick patient who had the bilirubin of almost 41, the elevated INR, very, very, very sick. So cyclosporin, propionuracil, um, protein restriction, steroids, or antibiotics. Yeah, so very good. Most of you are picking corticosteroids, which is the correct answer. That there is data that I'll share with you on survival benefit in our sickest patients who do not have contraindications to get corticosteroids. So this is sort of the landmark study that was published many, many years ago, where it showed a survival benefit at 1 and 6 months if you pick patients who had a discriminative function greater than 90. You don't give it to people actively bleeding and renal failure or if they have an active infection, and they get big doses of steroids, 40 milligrams a day for 4 weeks, then the taper. So, what are the things that are most helpful for survival with alcoholic hepatitis? Well, abstinence is the most important thing, as shown on this graph, that abstinent patients, 1 year survival 98%, 2 year survival 90%. Those who do not stop drinking, who are hospitalized with severe alcoholic hepatitis, only a 20% survival at a year, 10% at 2 years. Good nutrition's important, steroids, rarely liver transplantation, and now sometimes uh, giving N-acetyl cysteine or mucomist in addition to corticosteroids in selected patients. A 51-year-old man presents with increasing pain in his hands. He's found it harder to keep working at his job as a mechanic. Past history, diabetes, hypertension, and hyperlipidemia. He has a distant history of nasal cocaine use. On exam, he has swelling over the metacarpal phalangeal joints of his hands. His hemoglobin's 14, hematocrit's 42, ALT is 66, AST is 100, his albumin is 3, and I'll show you his hand film. So his chief complaint is his hands hurt and he's having trouble working, but you note that he's got diabetes, hyperlipidemia, and hypertension, this history of cocaine use, and he's got this swelling over the MCP joints, and you see his labs with the transaminase elevations. So here is the X-ray of his hand, of one of his hands. What is the most likely diagnosis? Alcoholism, hepatitis C, PCT, hemochromatosis, or sarcoid? Yeah, you're all over this one with all of you choosing hemochromatosis, which is absolutely correct. Hemochromatosis can cause a odd arthritis in the hands, and it tends to involve the MCP joints, and that is not are not common joints to be involved with regular osteoarthritis. As we go back and look at this X-ray, if I can get back there. Oh, maybe not. Anyway, the MCP joints were involved, and that's what you look for. So when people get odd MCP joint arthritis, it looks like osteoarthritis. Think about things other than regular osteoarthritis, and hemochromatosis is top of the list. Person also had diabetes, person had transaminase elevations, so they had several other things that would go along with hemochromatosis. So look for funny arthritis involving the MCP joints in the hands. Um, Diabetes, cardiomyopathy, liver, hypogonadism in men can be sort of a hidden presentation of this. So if you see somebody with transaminase elevations and coming in with concerns of hypogonadism, think about this. So the involvement are these joints here, as we saw in the X-ray. These are not involved. Okay, so it's these joints here. So the classic presentation of hemochromatosis is bronze diabetes. That is somebody who has a skin discoloration and usually kind of a more of a gray, dark discoloration. But that does not occur in most patients. When you look at the skin discoloration, it's 70%, but you're seeing liver disease in 75%. So you can't bank on everybody having skin discoloration. When you get that, it's really much easier to make a diagnosis of hemochromatosis. And then you have diabetes in half, hypogonadism in half, cardiomyopathy in 3/4. The best screening test is an iron and TIBC. And these patients will have like 90% iron saturation, and that strongly suggests a diagnosis. Ferritin is good too. They get very high ferritin levels, but we can get really high ferritin levels due to inflammatory states. So iron and TIBC is a wonderful screening test. Genetic testing has really become the standard now for confirmation. Liver biopsy is the old gold standard, and the only real effective treatment is phlebotomy. A 35-year-old man is denied life insurance due to increased liver enzymes. He feels well with no symptoms, no significant past medical history, not on any medications. Family history really is unremarkable. Drinks 3 glasses of wine per day, no tobacco use. Blood pressure is 120/80, pulse is 50, BMI is 23.9, no exam abnormalities, but his AST and ALT are both elevated. AST at 68, ALT at 70, alk phos is normal, bilirubin is normal. So a totally healthy person who was denied life insurance because he has elevated transaminases and was told to get it worked up, drinking 3 glasses of wine per day. What is the most appropriate management? Getting an ultrasound on him, a CT scan, liver biopsy, repeat labs in 1 to 2 months after abstinence from alcohol, or you really don't need to do anything. Yeah, the right answer here is have him do abstinence from alcohol for at least a month and repeat his transaminases. This is not an alcoholic hepatitis pattern, but patients can get transaminase leak with regular alcohol use. This person's drinking 3 a day, maybe he's drinking a little bit more than that. So the very first thing we do is remove toxins and retest. Um, an ultrasound, certainly some of you might be thinking, could he have fatty liver? But with the BMI of 23, he doesn't have other things to go along with MASH. So I think jumping to an ultrasound, I wouldn't do that before I'd remove potential toxins and retesting them. So we do have kind of a interesting way that we go ahead and do the workup of our elevated transaminases. The first is a simple thing: remove meds that could be a problem, remove alcohol, remove supplements, other things that could be a problem, and retest. So we always discontinue alcohol and any suspect drugs. We don't ignore abnormal transaminases because they can be the tip of the iceberg. So we always want to have an answer for this. So this does not preclude, these type of numbers don't preclude significant liver disease. So we do want to work that up. So your patient does what you say, zero alcohol at all for the last 2 months. You get more labs. AST is 55, ALT is 78, so still has abnormalities there. He now admits when you do the history again, he says something he didn't say initially. When you ask him about injection drug use initially, he didn't say it. And now he says, it was a long time ago and I'm kind of ashamed of it. But when I was in my 20s, yeah, I did a little bit. I did a summer of injecting drugs. What is the next test at this point? Ultrasound, CT scan, Hep C and Hep B serologies, Hep C PCR, Hep B PCR. Yeah, I think you all did very well on this. I would want to get Hep C and B serologies as my first step here in looking for a potential viral hepatitis because of his risk factor of past injection drug use. And especially for hepatitis C, history we all have seen many times of somebody with distant injection drug use, and then they feel fine, and then we pick up transaminase elevations, and then we end up finding hepatitis C. So his history and labs are most consistent with chronic viral disease here. Ultrasound CT isn't going to help us in this case. We don't really have anything suggesting a biliary tract problem here. And the serologies will measure past exposure. If negatives, if negative, then we can really feel comfortable that we've ruled out viral hepatitis, which is our leading diagnosis here. So what is our evaluation of patients with elevated transaminases? The first step is stop all alcohol, any offending drugs, supplements, recheck in a month. Step 2 is test for hepatitis B and C, test for hemochromatosis with an iron and TIBC. And at that point, if they have risk factors for NASH, now called MASH, get an ultrasound. Step 3 is if all this stuff is negative, we start thinking of some of the non-hepatic causes, muscle enzymes, other things that could be a problem. Step 4 is when we start looking for the zebras, things like autoimmune hepatitis, Wilson's disease. And then once we've done a complete workup, then we do watchful waiting of the transaminases are under two times upper limit of normal. If they persistently are elevated, then moving forward to a biopsy. So some of the non-hepatic causes of increased transaminases, muscle disorders, usually they have a higher AST, but the ALT can go up a little bit. And Keep that in mind. Hypothyroidism particularly can cause elevated transaminases because of proteoimmunoglycan infiltration of the muscles. Celiac disease can cause ALT elevations, and they tend to normalize on a gluten-free diet. So you may see patients where you have persistent ALT elevation, which may be due to celiac disease, and then much rarer adrenal insufficiency rarely can cause ALT elevation and anorexia nervosa. So a few pearls from this case: antibodies for Hep B and C show past infection, and at that point, if they have those, then we're going to go ahead and then check for viral loads for this patient. If this patient was positive for Hep C with antibody testing, we would move on to a viral load for them. Same thing with hepatitis B, and we can look at some of the other antibodies for Hep B to suggest that. So definitely verify the infection here. Now, the other thing I wanted to touch base on is alcohol is such a promoter of hepatitis C toxicity that not everybody with hepatitis C is going to end up getting inflammation and cirrhosis for it. And some patients will clear their hepatitis C, but when people drink, the likelihood of having cirrhosis is dramatically higher. If you look at cirrhosis risk in Hep C negative person versus a person with Hep C, it's 15-fold. If you have a Hep C positive individual who doesn't drink compared to a Hep C positive person who is an alcohol abuser, it's 147 times the relative risk compared to 9-fold just with hepatitis C positivity without adding alcohol. Now, a couple of comments on extrahepatic manifestations of hepatitis C. Certainly, the cutaneous vasculitis you can see with hepatitis C due to cryoglobulins, as you see here, is not all that uncommon, and fortunately does improve dramatically when these patients get care for their hepatitis C. Hepatitis C patients are not at risk for liver cancer until they develop cirrhosis. So that's when we start doing screening for them. Once it develops, 8 to 15 years for a liver to fail. And I'll leave this up to you for review on the more up-to-date standards of care for Hep C. We're now going to move on and look a little bit at some of the types of questions you might get on management of patients with end-stage liver disease. A 47-year-old man with end-stage liver disease presents for evaluation. He has a history of an MI and has osteoarthritis and gout. Which of these medicines should be avoided in these patients? Which of these is an absolute thing you want to avoid in this patient? Statins, NSAIDs, acetaminophen, or prednisone. So which of these is an absolute drug we want to avoid? So this one got a real spread of answers. And I think the answer here is NSAIDs, because this patient has a past history of MI, which NSAIDs will increase his risk there. A young person with an MI, I certainly would be concerned about adding the NSAIDs there. The NSAIDs can be a problem for the liver as well, but much more important is the GI bleeding risk in this patient who has end-stage liver disease by putting him on an NSAID. So I think the NSAID is a no-no. Then also the hemodynamic effects on the kidneys in a person with cirrhosis. We really don't want to go there. Statins are absolutely fine, and nobody picked that. I'm glad nobody picked that, and that there is some data of actually being protective in some patients with hepatitis C and liver disease. So acetaminophen, if they're using 2 grams or less a day, they should be fine, and prednisone should not be a problem here if we need to use an anti-inflammatory if there's a clear indication for prednisone. So acetaminophen is okay. Generally, in our patients with cirrhosis, we keep them under 2 grams a day. Statins are fine. NSAID shouldn't be used. A 45-year-old man with end-stage liver disease presents with abdominal pain. On exam, he has temperature 38.3, a pulse of 100, a blood pressure of 90 over 60. Abdomen, he has shifting dullness, ascites on handheld ultrasound. He's tender to palpation and with when you shake his abdomen. So just when you touch him and when you do a little shaking of his abdomen, he hurts a lot. White count's 14, sodium's 128, albumin's 2.3, creatinine's 1.2, bilirubin is 4.4. Paracentesis is done with 1,000 white cells with 80% polys. Albumin is 1. What do you recommend for him? Ampicillin, tobramycin, levofloxacin, cefotaxime, and albumin, levofloxacin and metronidazole, or ceftriaxone. So the right answer here is C, and this is a little tricky question because cefotaxime has some probably the best data for SBP from early studies, but we don't use it much. It's dosed multiple times a day. It is still an indicated drug for SBP, but ceftriaxone is perfectly fine for SBP as well. The problem here is this patient has multiple criteria for giving him albumin, and that may decrease mortality. So, because of the patient's creatinine, bilirubin, both of those would be indications for adding albumin to your antibiotic here. So, I think the right answer here is cefotaxime and albumin. Ceftriaxone is an excellent drug to use here for just treating the SBP, but you don't get the other beneficial effect you get with the albumin. Um, a couple of you chose levofloxacin metronidazole. With SBP, we just don't see anaerobe, so we really don't need anaerobic coverage. Levofloxacin would also be an okay antibiotic as far as coverage for this patient, but again, we need the albumin. So SBP is more common in patients with ascites and a high SAG. With the low proteins that we see in these patients who have liver disease, they're at risk for SBP. And we don't see much SBP in people who have malignant ascites because those tend to be quite proteinaceous ascites. Greater than 250 polys per microliter has a high sensitivity for SBP. Treatment of choice is cefotaxime or other third-generation cephalosporins for 5 days. And then do remember, if the creatinine's over 1, bilirubin over 4, or B1 over 30, they should get albumin on days 1 and day 3. A 44-year-old woman with end-stage renal disease and refractory ascites and esophageal varices on EGD 6 months ago presents for follow-up. She has been receiving large volume paracentesis, and it should be end-stage liver disease. I apologize for that error in the first sentence. End-stage liver disease, refractory ascites, esophageal varices on EGD 6 months ago, has been getting large volume paracentesis weekly for 6 weeks to try to manage her ascites. Meds are Cipro, propranolol, vitamin D, creatinine is elevated, sodium is 128, albumin is 2.4, peritoneal fluid, total protein is 1.1, blood pressure is 88 over 60, pulse is 60. What do you recommend? Stop her Cipro, increase her Cipro to 500 daily, increase her propranolol to 20 twice a day, or stop her propranolol. So this is a another harder question, and the right answer is D. Given given her severity of disease here, she actually falls into a group of patients that does not benefit from the beta blocker and may have trouble with it. So when we look at prophylaxis for patients with end-stage liver disease, quinolones are used for SBP prophylaxis if prior SBP or ascites fluid, total proteins less than 1.5, sodium less than 130, creatinine greater than 1.2, or BUN over 25. So she needs a fluoroquinolone for prophylaxis. Non-selective beta blockers for variceal hemorrhage prophylaxis if they have varices on EGD, but avoid in patients with refractory ascites because of the increased mortality in this group who get beta blockers. So this is a patient with severe refractory ascites, so we would be stopping the beta blocker in her. A 60-year-old woman with a history of end-stage liver disease presents with worsening confusion. She has a history of hepatic encephalopathy. Her family brings her in today because she's had 3 falls in the last 24 hours, including one this morning that was unwitnessed. Her daughter found her on the floor. Temperature of 36.6, pulse of 90, blood pressure of 90 over 60. She is jaundiced. Her abdomen is soft, non-tender. No fluid wave is present. Stool's heme negative. White count is 6. Crit 44. BUN 8. Creatinine 0.8. UA is normal. So brought in by the family because the patient's confused, been falling a lot in the last 24 hours. And this morning, the family was not there and she was found on the floor. So that was an unwitnessed fall. Low blood pressure, afebrile, jaundice. The rest of her exam is really unremarkable, and her white count's fine, crit's fine, BUN creatinine are fine, UA is fine. What is the most appropriate next test? Abdominal CT scan, non-contrast head CT, ammonia level, liver function tests, or a D-dimer? Yeah, I think most of you are choosing a non-con scan. That's what I would get here because she had an unwitnessed fall and she's got confusion now. And I think the main point of this question was to try to get people away from ordering ammonia levels. Ammonia levels don't really help us much here. I don't think it will be the correct answer on any board question. It's not, there's really no utility in following ammonia levels, and is little value in patients with known past hepatic encephalopathy diagnosis. So just grabbing it just to see if it's high, because really if it's not super high, it's not going to give you a diagnosis. Look for infection, GI bleeding being the most common two triggers here, and person didn't look like they're infected. They didn't had heme negative, that was tested to see if they were GI bleeding, and her crit was 44. So we did look at the most important things. And then with an unwitnessed fall or head trauma, then getting non-con scan is right. I wouldn't get a non-con scan if the patient has been followed closely and had no falls, just to get it for the heck of it. But in an unwitnessed fall, there's a clear indication for it. So to recap, don't choose ammonia levels and get head CTs if you have a reason. A 57-year-old man with woman with end-stage liver disease due to hepatitis C presents for follow-up. She was last seen 2 years ago. What testing do you recommend for her? Hepatic ultrasound and alpha-fetoprotein, hepatic CT scan, liver function tests, and alpha-fetoprotein. And then choice 5, a serum ammonia. Yes, all of you that voted chose hepatic ultrasound and alpha-fetoprotein, which is correct. This patient has cirrhosis, so they need to have a hepatocellular carcinoma screening, and the current recommendations from the American Liver Society and AGA would be to do ultrasound and alpha-fetoprotein every 6 months. So cirrhosis by itself is a risk factor for hepatocellular carcinoma. All with cirrhosis should be screened with Q6 month ultrasounds and alpha-fetoproteins. The highest risk are those who have hepatitis B and C and hemochromatosis. They have a higher risk for HCC compared to those who have alcoholic cirrhosis, but all cirrhosis does raise the risk. We don't use alpha-fetoprotein by itself as a screen. A 50-year-old male with a history of alcoholism presents with severe right upper quadrant pain, nausea, and fever. Labs, AST 45, ALT 35, alk phos 200, white count 17,000. Ultrasound shows 3 to 4 small gallstones with no paracolic fluid. So we got a 50-year-old with alcoholism and severe right upper quadrant pain, nausea, and fever. AST is up a little bit. ALT is right borderline. Alk phos is up a little bit. White count is up at 17,000. We get an ultrasound, 3 to 4 small gallstones, but we don't see any paracolic fluid. Doesn't really look too abnormal other than the gallstones. What additional test would be of best help in diagnosing acute cholecystitis here? This is a high stakes thing because if this person has alcoholic hepatitis and they don't have an acutely inflamed gallbladder and you go after the gallbladder, they have a high operative mortality. So what test do we want to get? Looks like you all like the HIDA scan, absolutely correct. This is one of the few clinical reasons to get a HIDA scan. Really, when you're looking to see if somebody has acute cholecystitis, acalculous cholecystitis, the HIDA scan can be quite helpful. Really doesn't have much benefit beyond that. So it's a very specific test for acute cholecystitis. A positive scan shows filling of the biliary tree, but not the gallbladder. And we like it for when we have a challenging case for acalculous cholecystitis or acute cholecystitis. We always lead with the ultrasound, but if the ultrasound doesn't give us an answer, then we can move to a HIDA scan if we have a high pretest probability for acute cholecystitis. A 54-year-old woman presents with severe abdominal pain for 2 hours. The pain came on suddenly and was 10 out of 10 in severity. It was in her right upper quadrant, radiating to her back. She has had a 50-pound weight loss in the last year. She is evaluated in the ED, and labs show an AST of 450 and ALT of 500 and alk phos of 100 and a bilirubin of 1.2. She receives morphine for her pain with minimal relief. An ultrasound shows multiple gallstones but no dilated ducts. A HIDA scan, no signs of acute cholecystitis. Her pain resolves 3 hours after arriving in the ED. Repeat labs 15 minutes after pain resolution. AST 900, ALT 1000, alk phos 130, bilirubin 1.2. So odd case here, somebody with horrible pain for a couple hours, 10 out of 10. She has had some intentional weight loss in the last year. Pain went to her back. She has transaminases elevated, alk phos isn't, bilirubin is pretty borderline. Get some morphine. Pain is still bad. Ultrasound shows multiple gallstone, no dilated ducts. HIDA, no acute cholecystitis. Now her pain goes away. But you decide, what the heck, let's get some more labs. And the labs show the AST and ALT are rising. The alk phos is 130, still not in the abnormal range. What is the most likely diagnosis? Acetaminophen toxicity, Hep A, ischemic hepatitis, liver fluke, or passage of a gallstone? So I think E is the right answer, but C is correct too, because the pathophysiology of the transaminase elevation is ischemia because of gallstone that was blocking for a period of time. And this is a something that I think somehow we don't get taught this correctly, that the first thing to happen when you pass a gallstone is your transaminases go up, and they can go up quite high. They can go up into the thousands with this. And it goes up before alk phos does. Alk phos needs more chronic obstruction. So, 18 hours, 24 hours, 36 hours, 48 hours, yes, you'll see the alk phos go up. But you see the person in the first 12 hours, it's generally AST elevated without the bilirubin, the alk phos going up. GGT is always our most sensitive test for obstruction, and the GGT would be up here if you did order it, but just recognize pain, right upper quadrant pain with elevated AST and ALT may well be a gallstone, and you sometimes catch them after the stone is passed and the transaminases are still elevated. A 46-year-old man presents with fatigue and pruritus, most prominently on his palms and soles. He has been more fatigued for the past several months. Has history of depression, GERD, ulcerative colitis with the colectomy many years ago. Meds are meds, sertraline and omeprazole. Blood pressure 100/60, pulse of 80, temperature of 36.7, eyes sclero-non-enteric, abdomen, liver 12 centimeters, splenomegaly is present, no fluid wave, no spider angioma or polymerythema. Excoriations are present on the arms. So 46-year-old man with a more distant history of, has history of depression, GERD, distant history of ulcerative colitis on omeprazole and sertraline. He's itching like crazy. AST is 85, ALT 90, ALK Phos 600, bilirubin 1.9, albumin 3, INR 1.1, crit 42, white count 5.6, platelets 120, BUN 15, creatinine 1, abdominal CT, small nodular liver, splenomegaly is present, and abdominal varices are present. What is the most likely diagnosis? Chronic Hep C, PSC, chronic, primary biliary cholangitis, and constrictive pericarditis. Yeah, so you all picked up on the ulcerative colitis history and the primary sclerosing cholangitis. He has this cholestatic picture here with the itching and all the numbers fitting. And in the United States, 70 to 90% of those who have PSC have an inflammatory bowel disease history, usually ulcerative colitis. There are parts of the world, I believe in Norway and Sweden, it's closer to 95% of individuals with this diagnosis have an inflammatory bowel disease history. I think on the boards, everybody who you're going to be diagnosing with PSC will have inflammatory bowel disease history. And just be aware that if they get a colectomy, it does not reduce this risk. So asymptomatic after colectomy, totally fine from an ulcerative colitis picture, they can still get PSC and their risk is not reduced by that. So this case, the itching suggests a cholestatic disease. PSC is generally in middle-aged men with inflammatory bowel disease history. So what test would you do to confirm this diagnosis? You think it's PSC, what's your best test here? Liver biopsy, a HIDA scan, hepatic ultrasound, or endoscopic cholangiogram? Yeah, we do want to do the endoscopic cholangiogram. That will be confirmatory. Really want to avoid biopsying these small cirrhotic livers. They're really higher risk to bleed, and we're not going to get a final diagnosis from that, but we will be able to be able to come up with a definitive diagnosis by the pattern we're going to see on endoscopic cholangiogram. So diagnosis of PSC is based on clinical, biochemical, and cholangiographic findings. And what do we see on cholangiogram? We see diffuse multifocal strictures of the biliary tract with dilation, or what's described as beading. This disease, 60 to 70% of the cases are in men. 50 to 100% of cases associated with ulcerative colitis. You see in Norway, 98%. In Italy, only 36%, which is interesting. Um, and it's a small percent of those with inflammatory bowel disease that go on to develop PSC. Cholestatic features, 80% will have a positive ANCA. They'll have signs of chronic liver disease, and then a typical cholangiogram. How would you treat this patient? What would be the best treatment for this patient? Ursodiol, colchicine, liver transplantation, or prednisone and azathioprine? So the right answer here is liver transplant. Now, it might be a little hard because you looked at the clinical features right now and you go, we were not going to transplant them today, but this person needs to get evaluated at a transplant center and be put on the transplantation list because that's the only thing that's going to allow this person a reasonable chance at a significant life expectancy in the long run. So none of these other things really change the course of PSC. Now, some of you might have chose ursodiol saying he's really itchy and just putting him on a transplantation list isn't going to help that. And I think that's fair. I think this question, if it was written by the ABIM, would be a lot clearer. They would say, what would be the best treatment for mortality for this patient, which would be a fairer question. So no therapy to date has shown major impact on survival or prevention of complications. So the bottom line for long-term survival is optimization of liver transplantation. Complications of PSC, itching occurs in all of these patients, and we can try different things to try to help that. Naltrexone, naloxone has some benefit. Cholestyramine has had some benefit. Half of these patients end up getting osteoporosis, so they all need to be treated for that. Supplemental calcium and vitamin D, bisphosphonates. They die from bacterial cholangitis. For many of these patients, they end up getting septic from this. And so having them have a low threshold for being evaluated if they get fevers or if they're feeling more tired and feel sicker, to be evaluated quickly because we fear so much this problem. They can get varices and bleed out from that. Cholangiocarcinoma, much higher risk of cholangiocarcinoma with PSC, and they can get fat-soluble vitamin deficiencies. A couple of comments on a couple of rarer diseases. Autoimmune hepatitis, it's seen generally in women between 20 and 50. Many of these patients have some other autoimmune disease, ITP, type 1 diabetes, thyroiditis, celiac disease, hemolytic anemia. All of these patients have hypergammaglobulinemia. 98% of these will have hypergammaglobulinemia if they get an SPEP. Say they get an anemia and they're getting worked up, they get an SPEP and they have massive hypergammaglobulinemia. Think about this diagnosis. Also, 80+% will have a positive ANA and anti-smooth muscle antibodies. And treatments, corticosteroids, very effective for this. And azathioprine being added to the corticosteroids can be very, very effective and can let you bring the steroid dose down as a steroid-sparing agent. A couple of words about Wilson's disease. The older the patient, the less likely they are to have Wilson's disease. I can't imagine that they're going to give you somebody over the age of 40 on the boards. It should be, in general, when writing these questions for the boards, we're supposed to write questions that are prototypical for rare diseases, not to give like an 80-year-old nursing home patient with Wilson's. It just would never be seen. So you're going to get a younger patient, Kaiser-Fleischer ring, sunflower cataracts, neuropsych. They may well present with neuropsych problems. So a Parkinson-like tremor, clumsy gait. They can also have uh, psychiatric issues as well. So think about that. If you get a 22-year-old that's got a tremor and clumsy gait, I'd be thinking about this diagnosis, and I'd also be thinking about a few other neurodegenerative things that can happen in younger people. Hemolytic anemia, that's a sort of a pearl here because people with Wilson's do get hemolytic anemia. They do get transaminase abnormalities. You might stumble on it that way. They can get chondrocalcinosis. Initial testing should be a ceruloplasmin level and 24-hour copper, as well as a slit lamp exam for Kaiser-Fleischer rings. If you suspect this and it's an important part of your diagnosis, then you should do all of this because the ceruloplasmin level alone may not be, you may miss it with that. A 55-year-old woman comes to you to establish care. She's only got fatigue, but you push her a little bit, and she says, when you ask her on a review of systems, she has some pruritus and her eyes have been dry. Past history, hysterectomy for fibroids 10 years ago, no alcohol or tobacco use. Exam spider angioma that you can see here, one on the nose, mild splenomegaly. Otherwise, her exam is normal. So splenomegaly and some spider angioma. Her labs have a bunch of things that are kind of stop us in our tracks. Her platelets are quite low at 90,000. Her bilirubin is up at 2, normal AST and ALT. She has a high TSH at 10 and a very high total cholesterol of 500. Her alkaline phosphatase is 450. Her albumin is 3. Her INR is 1.6. So low platelets, high bilirubin with normal transaminases, a very high alk phos, low albumin. INR is up, TSH is up, and a remarkably high cholesterol. What is the next most appropriate step? An ultrasound, a CT scan, a liver biopsy, further lab testing, or symptomatic treatment of itching and dry eyes? So the right answer here is further lab testing. Some lab testing will probably give you this diagnosis. Will be enough extra evidence with the overwhelming clinical evidence of what this disease probably is. So we want to do more lab testing here. So a few pearls here, for lab testing, viral and autoimmune disease has to be looked at. Imaging will confirm her cirrhosis, which you probably already know because she has splenomegaly, but probably not helpful in her diagnosis. And if cirrhosis is already clinically evident, a liver biopsy is not necessary. Liver biopsy is really just to see where on the spectrum she is with her liver disease, and in this case, is not going to be diagnostic. What is the most likely diagnosis in this patient? What do you think she has based on the physical exam, the history she had, and her labs? Chronic hep C, uh, primary sclerosing cholangitis, autoimmune hepatitis, primary biliary cholangitis, non-alcoholic fatty liver disease, or Wilson's disease. Yeah, this is very classic primary biliary cholangitis. This is very classic for it. It's the right age range, often presenting with a little itching, but a very high alk phos. And the thing that really jumps out us here is this incredible cholesterol. These patients get remarkably high cholesterols with extremely high HDL cholesterol. So that's sort of a pearl here that really suggests this diagnosis, the age of the patient, the numbers that she comes in with, a very, very high cholesterol. Further lab testing, viral titers, viral serology is all negative. ANA is negative, but the positive AMA is positive at 1 to 2560. So this one is very, 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 very helpful. And probably 90% of these people will have a positive AMA, has normal iron studies. Ultrasound just confirmed that the person has cirrhosis, splenomegaly, probably has portal hypertension. So pearls for PBC, um, chronic cholestatic liver disease pattern, where they will often show up with fatigue, itching, or frequently we pick this up just on our comprehensive metabolic panel when we see an alk phos at 600 or 700. Most are women. So PSC is mostly men. PBC is mostly women, and that's what you're going to get on the boards. Is they're probably going to give you a woman for this and a man for PSC. Age of onset, sort of 20 years around menopause. And antimitochondrial antibody is really a good test at 95%. And remember, it's usually seen with other autoimmune diseases. So look in the history. Do they have thyroid disease? Do they have a history of Sjogren's? You see this sometimes in CREST patients, so some other autoimmune disease. Serum cholesterol elevated in over 50% of these patients, and it can be remarkably elevated, but they aren't at risk of cardiovascular death likely because they have such an elevated HDL. These patients tend to have very, very low lipoprotein A levels that may be protective as well. Treatments for these patients, ursodiol may slow the progression, but it doesn't permanently slow it. They may help them with their itching, so we usually put them on ursodiol early, but we do get these patients to transplant centers. There are a couple of second-line treatments that have been proposed in the last 2 to 3 years, but they shouldn't replace ursodiol. They're generally used when a patient cannot take ursodiol because they have a reaction to ursodiol. Most commonly, these patients are itchy, and we can do naltrexone, naloxone, cholestyramine, a number of different things. Ursodiol is our go-to because of the help in progression of the disease, slowing that down, and it may help with the itching. These patients need to be looked at for osteoporosis and treated for that, fat-soluble vitamin deficiencies as well. Then if they have varices, non-selective beta blockers, and then they can also have problems with steatorrhea. A 37-year-old woman with a history of alcoholism is brought to the ED by friends with confusion and abdominal pain. Her friends report that she has been complaining of right-sided chest pain for the past 6 days. Her friends last saw her 2 days ago. On exam, she is confused and drowsy. She has right upper quadrant tenderness, labs, white count 13,000, bilirubin 9, AST 10,000, ALT 7,000. INR is 8. Oh my God, the INR is 8. So very messed up with very, very high transaminases of AST of 10,000, ALT of 7,000, bilirubin very high, and a tender right upper quadrant. Patient is pretty out of it. What is the most likely cause of her symptoms? Impacted stone in the common bile duct, hepatitis C, alcoholic hepatitis, acetaminophen overdose, or hepatocellular carcinoma? Very good. You all got this right. Acetaminophen overdose, such massively elevated transaminases. Nothing else on this list really fits that. An impacted stone in the common bile duct might bump it up to 1,500 for the transaminases, but she wouldn't have the INR where it is. She wouldn't have the confusion. Hepatitis C is not going to make that type of transaminase elevation. If she has end-stage liver disease and a cephalopathy from that, she won't have the transaminase elevation. Alcoholic hepatitis doesn't raise transaminases much, and hepatocellular carcinoma, those transaminases are way too high for that, and that would be an awfully acute presentation of that. So when you see massively elevated transaminases, always think drugs or toxin first. And acetaminophen is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 on your list. Certainly toxic mushrooms. I've seen several cases of that over the years. We sometimes see it with massive supplement intake that people take, and there are supplements. There are some herbs that some things that are used in big doses that can cause trouble. Hep A or B can do this. C doesn't cause this type of massive transaminase elevation. Acute ischemia, especially during surgery, could do this. And then very rarely severe autoimmune hepatitis, acute Budd-Chiari, and then in pregnant women, acute fatty liver pregnancy. A 47-year-old woman presents her evaluation of abnormal liver tests. She's had tests done for life insurance exam. The patient has no symptoms. She has a history of hyperlipidemia treated with atorvastatin. She's obese. Blood pressure is 140/70. Pulse is 80. No hepatomegaly on exam. AST is 88. ALT is 96. Alk Phos is 150. Glucose is 124. Subsequent workup, Hep C antibody negative. What is the most likely cause of her liver lab abnormalities? Is it MASH? Is it alcoholic hepatitis, toxicity from atorvastatin, hemochromatosis, or autoimmune hepatitis? Which of these fits this case the best? Okay, so you all got this one right. You're doing very, very well on my questions. I have a lot of tricky questions. You folks are doing great. So this really fits with MASH, and it does because this patient is on a statin. The patient is obese. The age fits very, very well for it, and looks like there may, potentially there could be glucose intolerance if this was a fasting blood sugar. So I would go with that. I think C is certainly not unreasonable to think about because statins certainly can raise transaminases. They don't cause liver disease, but they can raise transaminases. But because we've given you, she's got, lipid issue, glucose might be a little bigger, up a little bit, and the patient is obese, that's enough things that where I would weigh MASH over toxicity from atorvastatin. So this is very common. 7 to 9% of all liver biopsies. There are estimates now this is going to be the most common, if not already the most common cause for cirrhosis in the United States. More common in women, associated with metabolic syndrome, type 2 diabetes, hyperlipidemia, and obesity. Usually transaminases, ALT is a little more than AST, but alk phos doesn't go up much. The diagnosis is made by biopsy. We can strongly suspect it in patients with the right risk factors who have negative hepatitis serologies. Do FIB4 scores on these patients. That helps us know what their risk is and make decisions when we need to do fiber scans or sending these people for biopsies. What works for it? Well, gradual weight loss. Mediterranean diet is clearly the favored dietary weight loss for this. In patients without diabetes, there's evidence that vitamin E used to believe 800 units. There's a study was published a month ago that looked at 2, 4, and 800, and they all seem to be equally beneficial. So we don't know the dose of vitamin E, but in patients without diabetes, vitamin E may help. Patients with diabetes, semaglutide, uh, resmetirom, and pioglitazone all have been shown to be effective. Individuals who have bad MASH without diabetes, these drugs also can be effective. FIB4 score, you just need your AST, ALT, and platelet count to calculate it. If it's less than 1.45, the negative predictive value is very good for advanced fibrosis. Over 3.5 has a 97% specificity and positive predictive value of 65% for advanced fibrosis. So this is cheap and easy, and we should be doing this on our patients who we are worried about this. So I'm just going to finish with this last slide, just some things I want to just emphasize because these, I think, are very high yield test questions. Inflammatory bowel disease history and jaundice or increased alk phos. Think about PSC. Middle-aged woman with increased alk phos and pruritus, PBC. Antimitochondrial antibody elevation, most commonly in people with PBC. Anti-smooth muscle antibody, most commonly elevated in autoimmune hepatitis, and they usually have a positive ANA and all have hypergammaglobulinemia. Hand arthritis involving the MCP joints and liver abnormalities, think hemochromatosis. And please don't order a lot of serum ammonias on this exam. Okay, well, I'll stop there. And I know you're anxious for lunch break. You all did very, very well with this, and do want to wish you the best karma I can give you for this exam.
Thank you so much, Dr. Pao. And we will be very lucky to have Dr. Pao back for more talks tomorrow and Friday. And we will see everybody back at 1 o'clock.
We'll see you all tomorrow.